I think what we'd like to talk about now is concepts of prevention, where we are and where we're going. So when we have a number of things we've been using for prevention for a long time. For example, the guidelines talk about topiramate, divalproex, beta blockers, and tricyclic antidepressants. And I'd like to talk about them as a group. What do you think their strengths are, what their weaknesses are, and what do you think we could do to design new drugs that would improve on that? Stu.
The advantages of our current oral preventions are cost, they're generic, and access is easy, and occasionally there is an overlap between comorbidity and migraine. So one can use topiramate in a patient who is overweight. One can use divalproex in a patient with bipolar disorder. One can use a tricyclic in somebody with a sleep disorder and neck pain. One can use a beta blocker in somebody with hypertension. However, the disadvantages of these medications are very readily apparent. They were developed for other therapeutic areas. They were discovered fortuitously to have modest effects in migraine prevention. They require titration, generally up to a month, to get to the correct dose. They require 2 to 3 months generally to see modest efficacy, where responder rates are less than 50% of patients having at least a 50% reduction in their migraine days. And patients don't like them because of the baggage of adverse effects and the generally rather modest clinical efficacy. And in a study that I think David was on that was published in 2015 by HEP, more than 80% of patients who are given these medications are off them by the end of a year. It is very frequently an exercise in futility prescribing these medications for prevention.
So what you're really saying is when they work if you don't get side effects, but many people discontinue them because they don't work or they have side effects.
Those are the two clear reasons why people stop: lack of efficacy and adverse events.
What about Botox, Tim? David, you know a little bit about Botox?
Yeah, well,
a lot, I should say.
Botox, or Botulinum Toxin A, was, of course, approved in 2010 for the prevention of chronic migraine. It's not approved for episodic migraine because the studies were not positive in that. So that's one thing I will say. The second thing is it's an attractive treatment option to patients because patients, by and large, don't like taking oral medications. They don't like to feel sick and they don't like to take drugs. And so here's an opportunity to have something administered every 3 months that, by and large, is very well tolerated, really very little systemic absorption, so not a lot of systemic side effects that we currently experience with the available drugs that we have, like weight gain and hair loss and cognitive impairment, et cetera. So from that standpoint, and it has a long safety track record, used for other disorders. I mean, when you think about it, Botox has been used since the late 1960s. It was first used in kids with strabismus, and since then there have been a number of different applications and FDA approvals, from dystonia to blepharospasm and so forth. So it has a lot of different applications. So what that means is that the safety profile of the drug or the biologic has been around for a very long time. So patients are more comfortable with that, and physicians are more comfortable using it, knowing that safety track record, as opposed to something that was just approved and we don't have that clinical experience yet. And it works. I mean, obviously it works in those patients with chronic migraines. It doesn't work in everybody, of course, but in the clinical trials, about half of the patients had a greater than 50% reduction in the number of days they had with headache. And I would say that my clinical practice mirrors what we're seeing in clinical trials, that there's a substantial proportion of patients for whom they get benefit from this. And look, if you told me that I've got a therapy that's going to be well tolerated, that's going to help just a third of your more treatment-resistant patients, right, your chronic migraineurs who are really disabled, I would say, hallelujah, bring it on, right? And so if it just works in that proportion of people, then I'm happy. And so I have a number of patients who I've treated over the years who are very happy with that therapy.
Can I raise an issue? Botulinum toxin is given every 3 months and lasts for approximately 3 months. whereas all of the oral medications have to be taken on a regular basis, and many patients are non-compliant. Could it be that one of the reasons that patients drop off because of lack of efficacy is they're not taking their medications on a regular basis? So that's one question I think we need to think about and we don't know the answer to. And I agree with you 100% that side effects are an issue, but I'm just wondering if how much of the lack of efficacy is due to lack of compliance that's made up by having an injectable?
Well, I think that's a good question, Steve. I don't think we know the answer. One of my mentors showed that in Canada, 50% of patients, when they walked out with a prescription, never filled it or never took it. So non-compliance may be an issue, but the patients that you and I see are pretty severely disabled.
My best story is I was pushing amitriptyline a long time ago in one of my patients, and I thought it wasn't getting anywhere, it wasn't having side effects. She swore in a Bible she was taking it. I get the blood level back at 0. And I say to her, what's going on? I didn't want to disappoint you. So basically, the patients will not do what we tell them to do, but they'll tell us that not because they're lying, but they don't want to think we're not listening to them.
Well, I think that may be true in a small number, but I think for the majority of the patients we see, they're desperate, and they're desperate for help. And they take these medicines, I know, because they call me back, very freely to tell me about all the side effects they're having. So I really think side effects are an issue, and it's the reason why most patients, if I could get one of these drugs to its, if I could get to everyone on topiramate 200 milligrams, right, and they tolerated it well, it's going to work in a lot of people. But we simply can't get them there.
I think that there's a lot of times that, I like the 50% you just told me. Half the patients don't even fill the prescription. And it may be where we are in the food chain that accounts for the data.
I want to bring up one more thing about the Botulinum toxin issue. Works very well in chronic migraine. We use it in chronic migraine. But even with Botulinum toxin A, even in the patients in whom it's working, there are significant problems that have interfered with its effectiveness. The most important of which is that our payers are only allowing the injections every 12 weeks. And very frequently, probably in the majority of the patients, the Botulinum toxin is wearing off at 10 or 12, at 8 or 10 weeks, and there's a period of disability when the Onabot wears off, and then a period in which there requires the Onabot to kick in, and the patients can have anywhere from 2 to 4 weeks out of the 3 months in which they are not getting adequate prophylaxis from the Botulinum toxin A, even though in the first 2 months it's working. And this is actually turning out to be a very significant problem that when we bring it up with patients, we learn about.
I think one of the problems with preventives that worth saying, and maybe it's partly I think goes to compliance and putting side effects down for a second, is it must feel really weird on the other side of the table when everything we offer is not for migraine. Everything's not for migraine. Our colleagues in epilepsy don't offer diabetes drugs to people with epilepsy. They don't. I mean, it sounds crazy.
Right. Methylphenidate is the last drug we've had for migraine.
It sounds beyond crazy, and that was developed as that was actually developed initially as a drug for allergy, as I recall it. But it must be quite crazy to sit on the other side of the table and hear me say, you've got migraine, and then go through this pattern that we all have about, I'm going to give you this drug, it was designed for blood pressure, but it works in me. And we're the only branch of neurology that has that incredible disconnection between what we diagnose and then what we go and treat. And if I was listening on the other side of the table, I'd think, really? And that's, I think that's...
It's the same in peripheral neuropathies.
Yes, that we borrow. But to the point of that, on the other side of the table, when you tell a patient, I believe that you have a brain disorder, but I'm going to give you an antidepressant, they don't go home and take the idea that you listened and understood. Yep. They go, even if you try to explain to them that this antidepressant has been studied and I'm going to give it to you for migraine, there's a lot of back and forth.
I think if you have a migraine, if we had a migraine treatment, even if you had to take it every day, and if it was well tolerated and it was for migraine, I actually think things would be a lot better. We've gotten used to a really low standard of what we could offer, and we've done our best. Yeah. I mean, it's not like I'm not criticising anyone around the table at all. And I maybe if I was them, I would look at us pretty weird as well. And so I think it's going to be, that's why we're in such a transformational period because the whole conversation's turning on its head.